Good evening to all participants, PG students. Thank you so much, dear participants, for joining us, students and the PG students from nephrology, DM, DNB students. So we welcome you on behalf of Nephrology Division of RPG Life Sciences to the unique program, educational program, which is called as Nephrology Postgraduate Education Program. This is going to be the fourth session. We already had 3 sessions. So today on this unique initiative, the fourth session would be on present and future of immunosuppression drugs and protocols. Today we have our honored speaker, Dr. Sanjeev Gulati sir with us. So before I would introduce him, just those who have joined first time, let me just discuss you about the outline of this program and this total educational initiative that the objective of this is to connect the renowned teachers and the academicians from the field of nephrology to the students. Otherwise, it won't be possible. So because of this platform and the online studies, it is possible. So every session, every month, we are committed to come up with the one session on the different subjects which are pertinent to the postgraduate students. So we have 7 sessions. Today is fourth. And the 2 sessions would be based on PG students, like, how to draft the thesis or how to do the statistical analysis, how to calculate the sample size, or how to prepare for the DM exam or DMP exam. It would be all depend on the recommendations by the faculties and the PG students. There would be assessment and notes, and the notes would be shared, rewards would be there. And from next session, you would be eligible to download your e-certificates. And followed by, once we finish the program of 7 sessions, you will be getting the physical certificates for participation and the special rewards. So as I said, we had finished 3 sessions. Today, we would be speaking on the immunosuppressions, drugs, and the protocol. So we were blessed to have Dr. Chaco Jacob sir for our first session on kidney transplantation, past, present, and future. Then we had second session on the management of long-term post-transplantation complications. And we had Dr. Vishwanath Siddhini sir for our second session. And recently, last month on the 17th December, we had Dr. Shishir Gang sir with us to speak on clinical transplant immunology. And let me now, introduce today's speaker for the fourth session, which is on present and future of immunosuppression drugs and protocol. So I officially welcome you, sir. Thank you so much for giving us your valuable time. Dr. Sanjeev Gulati sir is he probably doesn't need the introduction, but as a part of a presentation, I am introducing him. He is presently working as a chairman of the Fortis group of hospital, and he has done DM nephrology, DNBA nephrology. And let me tell you, he is one of the very eminent academicians. You can see his papers, more than 30 scientific papers in peer-reviewed and index journal, national, international journals he has published in several journals. So, and not only that, he has authored several chapters, around 20 chapters in the textbooks, like, Oxford textbook of nephrology and the comprehensive pediatric nephrology. And he has written the books on the childhood renal diseases. So, my dear friend, this was a pleasure to introduce the sir. Thank you so much, and platform is yours.
Thank you, Dr. Mangesh, for this kind introduction, and good evening, friends. The topic that has been assigned to me is the present and future of immunosuppression drugs and protocols. Now, immunosuppression in kidney transplantation is certainly a very challenging job. And I'm reminded of this cartoon So when you are using or choosing immunosuppression, you are caught between a rock and a hard place. You give too little of immunosuppression, you end up with graft rejection. You give too much, you end up with infections. And even today, we do not have a good biomarker as to how should you tailor immunosuppression. So immunosuppression is, I think, more of an art than a science. There have been advances over the last few decades. We have had newer and more potent immunosuppressive agents. There are newer diagnostic modalities. We've had a reduction in the acute rejection rate. There's been definite improvement in the short-term graft survival. But yet, we have challenges in improving long-term graft and patient survival, and to minimize mortality in patients with a functioning graft. So when I started my career in nephrology, we had just 3 drugs at our disposal: steroids and azathioprine, and cyclosporin had just been introduced, and it had brought down dramatic reduction in the rejection rates, and the transplant, it gave a big boost to the transplantation. And as I progressed, we had several other therapeutic agents added to our armamentarium. Monoclonal antibodies, currently steroids still continue to be the sheet anchor. We have mycophenolate, tacrolimus, and the mTOR inhibitors, namely rapamycin and everolimus. Now, this is the kidney allograft. It shows the HLA class 1, class 2. This is the antigen producing cell. And when it interacts, it gives rise to a series of downstream events like interleukin-1 production, activation of CD8 T cells, C4D T cells, which lead to cytokines, interleukin-2, interferon gamma, etc. And there are different agents which act at different parts of this pathway. That is the rationale for using multiple agents in immunosuppression. As you can see, the CD8 T cells activation is inhibited by azathioprine, MMS, sirolimus. B cells again by azathioprine, sirolimus, clonal expansion. The cyclosporin, tacrolimus steroids act here by inhibiting the release of cytokines, interleukin-2, interferon gamma. And that's why if you use a combination of the CNI, steroids with one of these agents, you can achieve much better synergy and improvement in the graft survival. So this is in a nutshell what we use. We use an induction, and we have 3 agents at our disposal: basiliximab, which is an interleukin-2 receptor antibody. Then you have the anti-thymocyte globulin, or the ATG. Almetuzumab is officially still not available in our country. Campeth-1, it is a very profound inhibitor of T and B cells. So you choose one of these 3 agents. In India, we are still left with 1 or 2. But yes, when I was in Canada, we did use either of these 3, depending on the risk profile of these patients. So once you have done induction, then you come to maintenance. In the maintenance, we have generally the standard of care today is use a combination of tacrolimus, mycophenolate along with steroids. Some of us would prefer to switch our patients after a while to TAC, AZA, and PRED. Steroids are given daily. In children, to optimize growth, we have used alternate day prednisone. Steroid avoidance attained a good popularity briefly, but the downside has been the increased rejection rates. And we also have CNI avoidance protocols with this agent, belatacept. If you use, you can avoid CNI altogether. And we'll take a look at each of these groups of agents and see what are their pros and cons, what are the side effects to monitor. So this is what happens once the transplantation is done. This is the antigen presenting cell. This is the activation of the T cell receptor, which results in increased intracellular calcium. The activation of the calcineurin is a calcium-dependent phosphatase. The tacrolimus and cyclosporin, they are the 2 CNI inhibitors. they act slightly differently. Cyclosporin, as the name suggests, bind to cyclosporin, as the name suggests, bind to cyclopilin. Tacrolimus binds to the FK binding protein. Ultimately, both of them inhibit calcineurin and prevent the activation of the NFAT, along with downstream release of inhibition of all these interleukins. Now, induction therapy, the rationale has been that a brief, potent course of immunosuppression at the time of transplantation should be given because it results in reduction of the acute rejection rates, especially in the high-risk settings. And as I said, these are the T-cell depleting agents in the rabbit ATG and the anti-CD52 monoclonal antibody altuzumab. And we have the T-cell non-depleting agents. Tacrolimus was there for a while, but it has been withdrawn, and currently we only have basiliximab in this setting. Definitely, there is a reduction in the rejection rate, but it doesn't come without a cost. There is an increased risk of future development of lymphoma, especially with the T-cell depleting agents as compared to non-depleting agents, or if you are not using any induction therapy. So that's why the risk profiling of the patient is the key this is OKT3, which was again there for a while but is withdrawn. This is altuzumab. It acts at the CD52 on the activated T cell. This is the basiliximab. It inhibits the interleukin 2. It binds the interleukin 2 receptor and it reduces interleukin 2 secretion. So they are used, these biological agents are used in induction therapy, but they are also used, very useful agents for treatment of rejection. And the humanized antibodies are produced by merging the DNA that encodes the antigen binding protein of a monoclonal mouse antibody with the human antibody producing DNA. The chimeric antibodies use the same strategy for the variable chain and thus are more immunogenic than the humanized antibodies. And polyclonal antibodies and monoclonal antibodies can be depleting agents or immune modulators, as I mentioned earlier. These are the polylymphocyte sera. There is rabbit ATG, there is equine ATG. It can be given in daily doses of 3 to 7 days, but for most medium risk patients, we use about a 3-day protocol as an induction therapy in a dose of 3 milligram per kg. And definitely in rejection, we can use it for an extended period of time for up to 7 days. So this is how ATG acts by interfering with the immune response. There is a T cell depletion. It's a non-specific profound T cell depletion in peripheral lymphoid tissues, so the complement-dependent lysis and T cell activation and apoptosis. Along with that, the B cell, there is induction of B cell apoptosis also. And there is modulation of key cell surface adhesions and chemokine receptors that mediate the leukocyte endothelial interactions. And there is interference with the D cell function properties. And there is also induction of the Tregs and NK T cells. So currently we have two anti-thymocyte globulins in the market. One is the Fresenius ATG and the other is the other comes by the name of the Graflon, which is a basiliximab is actually a chimeric antibody with a specificity of CD25 and induces relatively mild immunosuppression and is used as an induction agent to prevent rejection, but not to treat established rejection. So it's only can be used as an induction. Although the exact mechanism is not fully understood, it is clear that there is significant depletion of T cells does not play a major role. And there is a saturation of the interleukin 2 receptor alpha unit, which persists for about 25 to 35 days after treatment with basiliximab. It is given in 2 doses, one on the day of surgery, 20 milligrams, and other repeated on day 4. Now, this is what is altuzumab I was referring to earlier. It's a humanized Ig1 monoclonal antibody against CD52, a glycoprotein found on the circulating T and B cells, monocytes, macrophages, natural killer cells, and granulocytes. It was first used in B cell chronic lymphocytic leukemia, but it's being used as an induction agent in renal transplantation, particularly in the high risk setting, or if you are aiming for a steroid free protocol. Now, it binds the alpha unit of the interleukin 2 receptor, CD25 25, this is upregulated on activated T cells, leads to expression of high affinity interleukin-2 receptors. There is engagement of the interleukin-2 receptors by interleukin-2, which triggers the activated T cell to undergo proliferation. There are no major side effects that have been reported, but yes, long-term risk of infections is there. Next, moving on to steroids, which even in 2022, continue to be the sheet anchor for the immunosuppression. Glucocorticoids, we use left, right, and center, but this is just to remind ourselves how profound immunosuppressants they have. They are very cheap. We know the side effects, so it's just like using a known devil. They activate the cytoplasmic glucocorticoid receptor, which then translocates. This is the receptor, it translocates to the nucleus and serves as an important regulator of the inflammatory process that is initiated through NF-kappa beta signaling here. Thereby it prevents the increase in the pro-inflammatory cytokines. It reduces the adhesion molecules, reduces the chemokines. So it's a broad spectrum, non-specific immunosuppressive agent. We generally give a single dose of 500 milligram on the day of surgery, followed by oral prednisone. The dose of oral prednisone has come down over the years. Currently, we use a 20 milligram dose starting on the day 1, that is after transplantation. And by the end of 3 months, most of us are down to a tapering dose of about 5 milligram daily. Next, we have the calcineurin inhibitors. We have the cyclosporin and TAC. And as I showed you earlier in the pathway, they selectively inhibit calcineurin, thereby impairing the transcription of interleukin-2 and several other cytokines. By inhibiting cytokine gene transcription, calcineurin inhibitors suppress T cell and T cell dependent B cell activation. Cyclosporin is a lipophilic cyclic peptide of 11 amino acids, whereas tacrolimus is actually a macrolide antibiotic. And both have been isolated from fungi, and they possess similar suppressive effects on cell-mediated humoral immune responses. These drugs, as I showed you, bind with either cyclophilin or FK binding protein, which are a family of cytoplasmic proteins present in the cells. And the drug receptor complex competitively binds to and inhibits calcineurin, a calcium, and a calmodulin dependent phosphatase. Blood concentrations need to be monitored because both of them have a narrow therapeutic index, which means that the difference between its therapeutic dose and the toxic dose is narrow, and generally the drug levels should be checked at least 2 to 3 days after any dose change. So this is cyclosporin. As I showed you, it actually by binding, it acts by blocking of the T cells by inhibiting interleukin-2 production and inhibition of proliferation and differentiation of T cells. Binds to cyclophilin, suppresses cell-mediated immunity. Tacrolimus, similar to cyclosporin, binds to FK binding protein. And the oral absorption in tacrolimus is variable and incomplete, and it is important to know that it is reduced by fat and carbohydrate meals. So generally, we advise our patients to take this drug either 1 hour before or 1 hour after meals, so that the absorption is stable and improved. It is highly bound with serum proteins and concentrated in red blood cells, metabolized by the P450 in the liver, which is important because several drugs which you might be using in these patients, notably anticonvulsants and antitubercular drugs like rifampicin, you need to be careful if you are using them together because they will dramatically reduce the tacrolimus levels. It is excreted mainly in the bile, minimally in the urine. So this is a comparison between the two. So variable bioavailability, 24% less, as I said, if we are eating rich in food. This is mostly fecal excretion. This is hepatic excretion. Binding is 98.8% here in the blood. Potency, tacrolimus is about 10 to 30 times more potent than cyclosporin, which is one reason now that practically it has replaced cyclosporin except for a limited set of patients. It has decreased the episodes of rejection. It has allowed us to use much lower doses of glucocorticoids, but notably it is more nephrotoxic and neurotoxic than cyclosporine. That's why drug level monitoring is actually a bigger challenge as far as tacrolimus is concerned. Next, we move on to azathioprine. Now, azathioprine was one of the first few immunosuppressive agents to be introduced in kidney transplantation. We borrowed it from our oncology colleagues. It is a purine analog that converts to its active metabolite 6-mercaptopurine and thiopurine by the action of this enzyme HPRT transferase as well as the TMPT enzymes. So this is this 6-thiouresyl, as you can 6-thiopurine is converted into thiosalicylic acid, then to 6-mercaptopurine, and azathioprine actually inhibits this and inhibits the purine synthesis by acting here. Its metabolites are incorporated into the replicating DNA and halt division, and metabolites may also mediate most of the immunosuppressive and toxic effects. Now, one notable thing is that you should not co-administer this with allopurinol, because this, results in increased thiouresyl in 6-mercaptopurine, which has profound bone marrow suppression. You can get leukopenia. So it can be used orally or intravenously. Also, oral is very simple and time-tested. And as I mentioned, co-administration with allopurinol may lead to toxicity due to inhibition of the xanthine oxidase by allopurinol. Side effects to be monitored are leukopenia, thrombocytopenia, GI toxicity, hepatotoxicity, and definitely mild increased risk of infections, but far less than other agents that we have at our disposal. So, although currently it's gone out of vogue, but most of us, are using the strategy of switch to azathioprine 1 to 2 years post-transplant, especially if these patients are doing well, to minimize the risk of infections, notably CMV. We'll look up to that. Moving on to mycophenolate, which is currently now the standard of care. This is a semi-synthetic derivative of mycophenolate, again derived from a fungal source. It's a prodrug. It is hydrolyzed to mycophenolic acid. It inhibits de novo synthesis of purines. It's a potent inhibitor of this enzyme, inosine monophosphate dehydrogenase, which is crucial for purine synthesis, leading to deprivation of proliferating T and B cells of nucleic acid. So this is how it works. Mycophenolic acid inhibits this enzyme and prevents purine synthesis. Here, the advantage is that you can, if you are pushed, you can use allopurinol and febuxostat along with mycophenolate, unlike azathioprine. Now, trough levels of mycophenolate appear to be lower by concurrent administration of cyclosporine. The effect is not observed with tacrolimus, because tacrolimus inhibits the UDP glucuronsyl transferase, the enzyme that metabolizes mycophenolic acid, thereby increasing concentration of mycophenolic acid. So if tacrolimus is substituted for cyclosporine in a patient concurrently on MMF, you can safely cut down the dose of MMF by about 50%. So instead of 720 twice daily, we are using 360 milligram twice daily if the patient is on a tacrolimus-based protocol. So MMF's immunosuppressive activity occurs after hydrolysis to this mycophenolic acid, and although MPA is the active moiety, it is formulated as MMF to enhance the bioavailability. And it has got profound immunosuppressive effect as compared to azathioprine. It reduced the depth sensor graft loss. As you can see, relative risk reduction of 78%, acute rejection rate of RR of 65%, and a chronic allograft nephropathy was reduced by 0.69. So this is a summary of the comparison of MMF versus azathioprine. 23 studies, 94 reports that involved nearly 3,300 patients. MMF reduced the risk of graft loss, death sensor graft loss. No statistically significant difference of MMF versus AZA was found for all-cause mortality. So very interesting. And pooled analysis failed to show significant and meaningful difference between MMF and AZA in long-term graft survival. An important thing to note is that there is an increased likelihood of tissue-invasive disease when you're using MMF, and this is a very important issue in our country, where most of us are background CMV positive. So there is a very high risk of reactivation of CMV if these patients are on high doses or on prolonged doses of MMF, so it requires monitoring. And that's why, as I mentioned earlier, a lot of us prefer to switch our patients from mycophenolate to azathioprine, where we do not see this CMV disease. Now, moving on to the next class of agents. After steroid, the induction agents, biologic agents, we talked about the CNIs, we talked about steroids, we talked about the purine synthetic analogs, and finally, we move on to the mammalian target of rapamycin inhibitors, the mTOR inhibitors, as we call it. They are proliferation significant inhibitors with immunosuppressive activity. And you have sirolimus, which is also known as rapamycin. This was the first mTOR inhibitor used in transplantation. It is a macrolide product, again derived from sirolimus. And then you have the everolimus, which is a rapamycin analog, similar mechanism of action, immunosuppressive properties, and side effect profile. mTOR blocked the progression of the activated T cells from G1 to S phase of the cell. This is an anti-proliferative action, which is unique. It does not block the interleukin-2 production, but blocks the T cell response to cytokines, thereby inhibiting the B cell proliferation and immunoglobulin production. And mTOR inhibitors have found its place in those patients where you are seeing CNI toxicity. They have allowed us to use much lower doses of CNI. So they have been used as a substitute for MMF. Again, they also have the advantage of minimal risk of CMV and BK virus infection, which is an issue when you are using tacrolimus MMF-based regimens. Coming back to the biologic agents, there are certain other biologic agents which are used mainly as anti-radiation protocols, and these are polyclonal antibodies which are used in, as I said, the humanized antibodies are there, the chimeric antibodies are there, and polyclonal and monoclonal antibodies are there. So we now move to rituximab. We have talked about the ATG. We have talked about basiliximab, as I said, is not used in the treatment of rejection. Altuzumab, anti-CD25, has been used. And rituximab is an engineered chimeric monoclonal antibody that contains the murine, heavy and light chain variable regions directed against CD20 plus a human IgG1 constant region. The CD2 targets the CD20 antigen. It's a transmembrane protein. It is found on immature and mature B cells and on malignant B cells. CD20 mediates proliferation and differentiation of B cells. And rituximab is a part of the therapeutic protocol that we have used in ABO incompatible transplantation, and it has also been used to treat. There are reports of it's being used to treat antibody-mediated rejection, especially in our country where eculizumab is not available. So this is what I was talking to its use in ABMR. It can be used combined with IVIGG, intravenous immunoglobulin, and induction therapy, and also in post-transplantation lymphoproliferative disease, as well as in recurrent FSGS. So PTLD and recurrent FSGS, if you find this is a very effective agent to use. Intravenous immunoglobulin. These are products known to have powerful immunomodulatory effects in inflammatory and autoimmune conditions. The mode of IVIG is not well understood, and in renal transplantation, the most important effect appears to be a reduction in the alloantibodies that inhibit antibody production and increase catabolism of circulating antibodies. There is inhibition of complement-mediated injury, inhibition of inflammatory cytokine generation, neutralization of circulating antibodies by anti-idiotypes. So it has been used in combination with plasmapheresis, especially to reduce the rebound increase in the antibodies as an adjunct in antibody-mediated rejection, and also in induction therapy in ABO incompatible transplantation. The benefits of IVIG are it causes desensitization of the positive cross-match. As I said, in ABO-incompatible patients, it allows successful transplantation as well as a very useful agent in antibody-mediated rejection, especially in our country where eculizumab is not available. So, alone or in combination, rituximab or IVIG has been used in desensitization of highly sensitized waitlist patients to increase the chances of finding a compatible donor. Next, moving on to another biologic agent, belatacept. This is a co-stimulation blockade. It is an immunosuppression alternative for kidney transplant patients, especially in those where there is CNI toxicity, and it is a first-in-class co-stimulation blocker. It's a fusion protein that binds to CD80 and CD86 on the antigen-presenting cells and thereby inhibits the T cell activation and proliferation. De novo kidney transplantation is one of the indications if there is EBV positive, seropositive adult patients. It has also been used for conversion from CNIs after renal transplantation, as I mentioned earlier, to a CNI-free protocol. The only disadvantage is it has to be given intravenously. It inhibits the proteasomes, which are enzyme complexes that regulate protein homeostasis. Next moving on to bortezomib. Bortezomib is it inhibits the proteasomes. It's another biologic agent which we use in antibody-mediated rejection. It inhibits the chymosin-like activity in the 26S proteasomes. It targets the rapidly proliferating antigen-producing plasma cells, but also interferes with the T cells and interleukin and TNF production. This is how the belatacept acts. It's still not available in our country, but it is being used in the West and it's likely to be introduced soon. So this is something which is there on the horizon. Next, we move on to eculizumab. Eculizumab is a humanized monoclonal antibody directed against the complement protein C5. It prevents the cleavage into C5a and B. It blocks the subsequent formation of the terminal complex C5b9 or membrane attack complex, and it has found its place as a very useful agent in the treatment of antibody-mediated rejection. It is usually reserved as a rescue therapy for allografts resistant to other anti-rejection therapies. Mind you, we need to make sure that these patients have received meningococcal vaccine and they are on antibiotic prophylaxis because there is increased risk of meningococcal infection after use. This is bortezomib, as I mentioned earlier. This was an anti-neoplastic agent approved for the treatment of plasma cell dyscrasias, several lymphomas, off-label indication for primary and refractory antibody-mediated rejection. And herpes zoster prophylaxis is recommended. So, what is the prognosis as far as kidney transplantation is concerned? You do have episodes of acute rejection which may predispose to chronic graft dysfunction. There are changes in renal function about from 6 to 12 months post-transplant, which are more predictive of long-term graft survival than the occurrence of prior episodes of acute rejection. So you need a careful follow-up. Acute T-cell mediated rejection responds to therapy well with return to near baseline function that does not portend worse graft survival. Vascular rejection is a late rejection and rejection that do not respond with 75% return to the baseline serum creatinine ratio with worse graft outcomes. And the emergence of de novo HLA antibodies remains a challenge and predicts a poorer outcome. So to sum up, high-risk patients benefit from induction therapy with lymphocyte depleting agents for prevention of rejection. So you need to stratify your patients into high, intermediate, and low risk. For high-risk patients, you should be using the lymphocyte depleting agents. For medium-risk patients, you can use basiliximab. For low risk, you do not require any induction agent. Most effective maintenance immunosuppressive regimen is a 3-drug regimen using tacrolimus, mycophenolate, and prednisone, followed by switch to tac-aza and prednisone. One drawback of MM has been its GI toxicity, which results in reduction therapy with attendant risk of acute rejection and graft loss. Steroid minimization can be done by using effective induction and belatacept-based CNI-free immunosuppression has been measured with adequate short and intermediate term outcomes, but should be limited to those patients who are at lower immunologic risk for acute rejection. And I end on this note from a quote by Dr. R. Douglas, who was a famous transplant surgeon. And this is what I tell my patients, that renal transplantation is like marriage. It means benefits for many, curse for some, but risk for all. And in today's era, we have a lot of therapeutic agents at our disposal to prevent rejection, to treat rejection, and we need to tailor these immunosuppressive agents to the risk profile of these patients so that we can achieve long-term graft survival with minimal risk of infections and rejection, which is the art and science of as far as the kidney transplantation is concerned. Right. So that brings us to the end of this presentation. And if there are any questions, I would be happy to take them.
So I would request participants to type their question in Q&A box. They can avoid putting it into the chat box. So there is a Q&A.
I think we have a question from Dr. Rajesh that, yes, what is the difference between Graflon and ATG? Yeah, both are rapid preparations, but Graflon has some degree of selectivity. It targets certain specific group of T cells as compared to ATG, which is a bit more non-selective. Head-to-head studies between ATG and Graflon have showed that at least in the high-risk patients, ATG appears to be a bit more superior, but in the intermediate risk patients, Graflon may be a useful therapeutic agent. Doses are entirely different, mind you. So that was regarding ATG and Graflon.
Right. So for the benefit of participants, there are a few questions. So what is your practical approach towards acute T-cell mediated rejection?
So yeah, so acute T-cell mediated rejection we treat with methylprednisolone 500 milligram daily for 3 to 5 days, depending on the severity of rejection, followed by oral prednisone. And majority of these T-cell rejections, if they are diagnosed in time and managed well, do not have a long-term kind of implication if they revert completely.
What's your opinion on desensitization protocol and the ABO incompatible transplant?
So coming to desensitization protocols, yes, these are in high-risk patients, those who have sensitized patients, and this requires a good lab backup using Luminex single antigen beads, which is this is entirely a separate topic in itself. But these patients require much more aggressive immunosuppression. We generally select these patients carefully, start them on immunosuppression much earlier, on day minus 14. Rituximab, as I mentioned earlier, is one of the very useful agents in this scenario. We give a dose on day minus 14 and we continue to monitor the antibody levels by giving single antigen bead. And once we are below an MFI of say about 1,000 if possible, we go ahead with kidney transplantation. Plasma exchange is a very important adjunct along with intravenous immunoglobulin as a part of the desensitization protocol, both pre as well as post-transplant if you are finding rebound agents. As far as the antibody-mediated, ABO incompatible transplantation is concerned, there's a lot of similarity, between desensitization protocols as well as the ABO incompatible transplantations, except that the dose of rituximab is a bit lower in the ABO incompatible transplantation. Most of us now are using 200 milligrams of rituximab as compared to earlier doses of 500 milligrams with or without plasma exchange, depending on the blood group treaters. But both these scenarios, you need very careful monitoring for risk of infections, and infections can be life-threatening in both desensitization protocols as well as the the ABO incompatible kidney transplantation.
All right. Now we have a question, I think, which might be repetition. Graflon and basilizumab. Any study to compare both of these?
Graflon, no, there is no head-to-head trial, but as the name suggests, the Graflon is a polyclonal antibody, and therefore it is far more potent than basiliximab. So basiliximab is a very selective anti-CD52 antibody. It is and it is definitely less potent. So it depends on your risk profile of your patients.
Yeah. One attendee is asking, what's your experience with Graflon? Have you?
Yeah, we have been using Graflon for a while. As I said, it is a relatively selective inhibitor of T cells. So our experience has shown that the CMV disease is definitely lower in those patients whom we have used Graflon. But at the same time, you should avoid using it in your high-risk patients because it is definitely less potent as compared to ATG. So I reserve it for my intermediate risk patients where the HLA match is good, but yes, there is history of blood transfusion, or there is but if the HLA mismatch is there, like if you have a 6 antigen mismatch, or in our second transplants or as part of our desensitization protocols, I would still prefer ATG.
Right. Dr. Himanshu Jain is asking high risk versus intermediate. How to stratify any guideline in live and disease?
Yeah, so you have to take a number of criteria. It is not one criteria. So second transplants, especially those where you have anti-Luminex antibodies, our levels are high risk patients. ABO incompatible transplantation are high risk patients. Multiple blood transfusions, I think I would put that in a high risk patients. Antigen mismatch. So if you have a 6 antigen mismatch, it is high risk. If it is lesser antigen mismatch between 3 to 6, I mean 3 to 5, I put it in the intermediate risk. And other than that, second transplants without antibodies, if you monitored your Luminex single antigen beats and the antibodies are not there, anti-HLA antibodies are not there. So those again would come in your intermediate risk. So my low risk is a good anywhere between 3 to 6 HLA antigen match, would be a low risk criteria.
Right. Dr. Rajesh has asked, what is your take on single dose of ATG on day 1 over 3 days?
So it's a good question. Some centers are using a single dose of 3 milligram per kg. Others are using divided doses of 1 milligram per kg in 3 doses or 1.5 in 2 doses. I think it is probably there's no head-to-head trial, and you can use whatever you are comfortable with.
Right. So Dr. Manjit Pal Singh is asking, inducing and using pre-transplant chimerism. What is your experience?
Can you repeat that again, please?
Inducing and using pre-transplant chimerism.
Chimerism.
Yeah.
I'm not sure. Would you like to elaborate it a bit further?
Yeah. I would like to ask Dr. Manjit Pal Singh to just put some light in details.
Further, can you just elaborate it a bit more?
Before he types and elaborated, there is always a debate on the ASA versus MMF, which is
Yeah.
so what's your clinical experience and how
Yeah, I
you
think for a
kind of
company like us with a background CMV positivity in our donor population of more than 85%, this is very relevant. CMV disease was almost unknown, at least in my experience. We used to see when we were using azathioprine based protocols, we used to see once in a couple of years. But the moment we have been using MMF, it's become far more common. But yes, the advantage has been a dramatic reduction in the rejection rates and acute rejection rates, chronic allograft nephropathy. So one has to tread the middle ground, and one of the effective strategies which we have shown in our paper, which was published in Indian Journal of Nephrology is to convert these patients after a while. Those patients who are doing well, you need to choose your patient very carefully. Good graft function, no proteinuria at all, reasonably good HLA match, 3/6 match. You can safely convert azathioprine. You can also, in your low risk patients, if financial issues are there, along with the availability of tacrolimus, you could also use azathioprine right on day zero as induction. Again, as I said, I'm qualifying it that there is a low risk, a good HLA match is there. So, azathioprine, even in 2022, I think retains its place as a very useful agent. And the cost in Indian scenario, the other advantage is cost. There's a dramatic cost benefit as far as azathioprine is concerned. And then also we have patients who are intolerant to MMF. They develop diarrhea, and those patients we have switched earlier on to azathioprine, even within the first few months. So in these scenarios, azathioprine is a useful agent.
Right. Someone is asking, what is your experience on only steroid induction without ATG in live transplant in current scenario?
Steroid induction without ATG. So living-related transplant, certainly yes. Steroids, as I mentioned, 500 milligram methylprednisolone. If you have a 3/6 match, there is no history of previous transfusion. It is a first transplant. Financial issues are there, yes. We often do that. No induction. Again, it's a joint decision taken between the transplant team and the family. We involve them in our counseling, and we tell them that this is certainly an option if finances are an issue, because there is no conclusive study which has shown that it good in a low risk scenario. The basiliximab induction adds in any way to a tacrolimus based protocol.
Right. Dr. Azhar Hassan is asking that in what type of patient will you avoid giving induction?
What type of patients? Okay. So low risk patients, first kidney transplant, good HLA match, more than 3 antigen HLA matches there. No history of blood transfusions. No, and there is in females if they have never been pregnant. In male patients again. So these patients, I would certainly not use this protocol.
All right. And Dr. Rajesh is asking, are there any other situation like where we completely avoid induction like HLA 12/12?
Yeah, HLA 6/6 is the way to talk about. Yeah. So if you are lucky enough and you see one of these patients occasionally where a sibling is donating and you have a 6/6, as I mentioned earlier, anything more than 3. So if you have 4/6 match, 5/6 match, 6/6 match, even in 3/6 match after careful counseling, you need not use induction agent. We have published a study in Indian Journal of Nephrology on the lack of benefit of any induction in a tacrolimus-based immunosuppression in a low-risk scenario.
Right. Always they cite that steroid minimization and CNI protocols in the textbooks, and also, what's your opinion on this?
Yeah, so steroid avoidance, I think, caught the fancy almost a decade back, especially in children. Mini Sarwar's group, but mind you, they use decluzimab or ATG, so you have to be careful. In our scenario, I think an alternative way would be, to use alternate day steroids after 1 year. That's what I practice as steroid minimization. And we have, again, I have published this, our experience when I was in Australia, where we were using the alternate day protocols in children with reasonably good growth rates. So steroid avoidance has been assured with a higher risk of rejection. And in our country, where it's a live-related program and one graft is perhaps your best chance, absence of, a good cadaveric program offering you a second chance, I am avoiding steroid avoidance protocols.
All right. What likely you see that the molecules will become, in the I think question must be, what are the futuristic
Yeah, okay.
pharmacotherapy?
Yeah, I think that's a very interesting question. And I purposely, because of time constraints, I thought we could discuss it. So there are new agents in the pipeline. Now, one is an NTCD11A inhibitor. Then we have the humanized variety of the belatacept. It's called second generation CTLA4 immunoglobulin. Then there is humanized anti-B7 molecule that is there in the pipeline. And there is also inhibitors of protein kinases, namely JAK3 inhibitors, which have been used in rheumatology and by our oncology colleagues. So there are several studies that are going on, and I think soon we'll have more therapeutic agents at our disposal.
Right. So I think the questions are over. So thank you. I would like to. What's your concluding remarks, sir, today?
Okay, I think there's one more question. Role of IDS.
Yeah, I think.
Yes, it is not available in our country, but yes, it is a potent agent that has been used as to manage antibody-mediated rejection. This is another agent that we look forward to being available. It's already there.
I think Manjit Pal has explained. Dr. Manjit Pal has explained that that chimerism. No.
Okay.
So he has in chat box.
Just open up. Yeah. Continuing mixing of donor and recipient hematopoietic cells and recipient tissues after transplantation. Yeah, this is I think still in the experimental stage. Where we expose one of the strategies was to use donor specific transfusion. There were a couple of studies that came in where before transplantation we are using blood transfusion from the donor given to the recipient and trying to achieve chimerism. But I think there is a lot more that is still required in this era. And the other era which appears promising is the xenotransplantation. I'm sure all of you must have been aware of a couple of months back in Pittsburgh. What they did was they transplanted a humanized kidney from a pig onto a brain dead individual to look at a proof of concept study, and they did find that there was a continuous blood flow in the kidney. So in times to come, xenotransplantation, I think, appears very promising. Again, it would require potent immunosuppressive agents. So as newer agents come in, I think that is going to be a reality.
Right. So what's your concluding remark for today's participants and students?
Okay. So yeah, as I mentioned earlier, the use of immunosuppressive agents is both an art as well as science. When you are young, you are very aggressive with immunosuppression. I say this from my own experience. But as you tend to follow up these patients longer, you realize that sometimes this aggressiveness comes with a cost. As I told you, that we have had very potent and continuous introduction of newer agents, but the long-term graft survival remains an issue. And still today, in a country like ours, infections remain a very important cause of death with a functioning graft. So when you are choosing your immunosuppressive protocol, you need to tailor that to the risk profile of this patient. The goal just should not be to get this patient out of the hospital in the first week with an reduced acute rejection rate. What we should be looking at is the long-term effects of these potent immunosuppressive agents, which, once you follow up these patients longer, you wish that maybe, you should not have been so aggressive earlier on, or you should have switched this patient on from mycophenolate on to azathioprine once these patients are stable. Because infections, I think, I repeat again, in a country like ours, remain the most common cause of graft loss. Again, they say hindsight is the wisest side, but this is all I can tell you, that you need to temper your enthusiasm to use these newer potent immunosuppressive agents, keeping in mind the goal of reducing the infection rates and improving the long-term graft survival.
All right. Before I go into the next my next session, Dr. GB Chandra has asked something. The possible, is it possible that mother and daughter HLA 6x6 match? So before
Mother
we
and daughter 6x, certainly. So mother and son 6x6 HLA match we have seen in our practice, and one thing could be that if the marriages, especially in some communities, there is a lot of inbreeding and marriages tend to happen within the family. So yes, you might see a 6x6 match between a mother and a son or a mother and a daughter. Yeah.
So I would like to assure our participants that followed by this session, you would be getting the assessment link. So where you have to answer the questions, and based on your score, so you would be rewarded. But from the next session, you would be able to definitely download your e-certificates, which are endorsed by the speakers like Dr. Chako Jacob sir, Dr. Sanjeev Gulati sir, Dr. Siddhini sir, and Dr. Shishir Gang sir. So those certificates, individual certificates, would be available. You would be able to download it after the fifth, when we will be having fifth session. And definitely you would be getting the recorded video of this session, as well as scientific notes to be referred. So before receiving question and answer questions, you would definitely getting the scientific notes, and then followed by the questions, and then followed by the video. So thank you so much for participating and listening to our session. And I would like to thank Dr. Sanjeev Gulati sir for sparing the time and situation around the India and the Delhi and Maharashtra is going somewhere else, but still we would be able to catch up online. That's a great thing, and I would like to thank all of you, including our today's speaker.
Thank you, Dr. Mangesh. I think I would like to compliment RBG, especially for taking this educational initiative, especially in this era of COVID, where the learning has suffered because of obvious reasons, and webinars have become an excellent way to pull in talent and continue this teaching during the COVID era. It's I think, a very laudable objective, and wish you success in this venture.
Definitely. So thank you so much for your encouraging words, and definitely we would be having more 3 sessions, and including 2 more based on the PG's recommendations. So thank you so much. Stay safe, stay healthy. Thank you.
Goodbye. Bye-bye.